Hello and welcome to another live broadcast with MedStar Health. My name is Sarah Ridenauer, and today we're discussing heart valve disease, what it is, the risk factors and symptoms, and the latest treatment options. In fact, do you know that 3 out of 4 Americans know little to nothing about heart valve disease, yet as many as 11 million Americans have it? Fortunately, valve disease can often be successfully treated in patients of all ages. Although heart valve disease risk increases with age, it is not a normal part of aging. Today is the perfect time to understand the risk factors and recognize the symptoms so you know when to seek care. Our panel of experts includes cardiac surgeon Dr. Jeffrey Cohen and interventional cardiologist Doctors Antony, Kaliyadan, and John Wang. We also hope to be joined by another cardiac surgeon, Dr. Christian Shults, throughout the broadcast. So if you have any questions for our experts, please ask them in the comments below, and also give us a like to let us know you're watching, and share this broadcast with your friends and family. Before we get into our questions, let's start by meeting our experts. I'll start with you, Dr. Wang.
Hi, thanks for having me. My name is John Wang. I'm the director of the cardiac cath lab at MedStar Union Memorial, as well as Franklin Square up in Baltimore, Maryland. I run the structural heart program, and I also run the clinical research program for cardiovascular medicine in the Baltimore North region.
Great, thank you. Dr. Kaliyadan.
Hi, my name is Anthony Kaliyadan. I'm the Associate Cath Lab Director here at Union Memorial, and I'm involved intimately in the structural and coronary program, full-time interventional.
Thank you. And Dr. Cohen.
Hey, I'm Jeff Cohen, and I'm a cardiac surgeon down here at Washington Hospital Center, and the surgical director for the structural heart program here.
Great, thank you. Thank you all for joining us to answer our questions. So let's get into it. Dr. Kaliyadan, I'll start with you. Starting with the basics, can you explain the function of the valves in our heart?
Yes. So the simplest way to explain what the valves do, the valves are essentially flaps of tissue which regulate the flow of blood between the different chambers of the heart. You can think of them as essentially very simplistically as doorways between the different chambers. And these valves open and close with the different cardiac cycles in order to regulate the flow of blood in and out of the chambers, and also out of the heart and into the heart as well. And it's important that each of these valves are functioning at the sort of optimal level so as to prevent leaks and to prevent adequate forward flow of blood throughout the heart.
Okay. And can you explain each of the valves, the aortic, mitral, pulmonary, you know all of them. Can you explain them for us, please?
Yeah. So there are four major valves in the heart that we follow. So starting on the right side, the first valve which we encounter is the tricuspid valve, which is between the right atrium and the right ventricle. And then the next valve that we encounter is the pulmonary valve, which is located between the right ventricle and the pulmonary artery. And then the blood gets oxygenated and comes back into the left side of the heart. And we then encounter the mitral valve, which is located between the left atrium and the left ventricle. The left ventricle is the main pumping chamber of the heart. Once we exit the left ventricle into the aorta, the main valve which regulates flow of blood between them is the aortic valve. And so basically, as the left ventricle contracts, the aortic valve will close and the mitral valve will open, and that allows the blood flow from the left atrium into the left ventricle. And that's and then same when you have that those are the four major valves, and that's sort of their function is to open and close and allow blood to move forward and not come back when the different chambers are contracting.
Okay. Thank you for explaining that. What is heart disease and how does it affect the way the heart functions?
So anytime we talk about valvular heart disease, we are talking about reasons why the valves or these doors inside our heart are not opening and closing effectively. So there are different etiologies for leaking or regurgitation or stenosis or narrowing of the valves. The way it can cause problems is if there is, for instance, stenosis of, say, the aortic valve, or that can contribute to the left ventricle not being able to eject or output blood to the rest of the body, the organs, brain, etc. And it causes more strain and stress on the left ventricle. In the same way, we also deal with stenosis of the mitral valve. That can also cause high lung pressures and arrhythmias and abnormal heart rhythms, and that can eventually lead to failure of the right-sided ventricle, whereas aortic stenosis, when it's long-standing, can lead to failure or weakening of the left ventricle. So the other issues we deal with are leaking of the valves. So with mitral regurgitation, we oftentimes see patients develop heart failure. We can develop excess fluid. We can develop arrhythmias associated with this. And, it's really important to sort of identify, the timing of when patients start to develop symptoms, because a lot of times, a lot of these valve issues can be very insidious and can go on for quite some time without symptoms. And, we can find with time, is when patients develop symptoms from these problems.
Okay. So speaking of symptoms, that goes into my next question of what causes valve disease to develop, and can it develop without any symptoms?
So there are many causes for valve problems. You can sort of put it into two buckets. You're either born with a lot of the problems, which we call congenital valvular disease, or you acquire valve disease as we get older, or get certain illnesses and things that can contribute to dysfunction of the valves. So for instance, one of the most common causes of one of the things we just talked about, stenosis of the mitral valve, is rheumatic heart disease. And we see this not so much in the United States, but we see this in other countries across the world, because patients can get rheumatic fever, and then these things over time can lead to rheumatic mitral disease and even rheumatic aortic disease. These are not common things we see here, but that is one of the big causes. Sometimes people are born with only 2 leaflets instead of 3 leaflets on one of their valves, the aortic valve. So all of the valves except for the mitral valve have 3 leaflets. The aortic valve, when it has 2 leaflets or even 1 leaflet, that's called either bicuspid or unicuspid. These conditions can preclude patients to develop narrowing or leak of the valve much earlier in life than we would expect, sometimes in their 40s and 50s. So these are other reasons why people can get valvular disease. There are certain medications, infections of the valve. These can all cause either leaking or regurgitation. Sometimes we see patients who have had radiation therapy. They can develop stenosis or narrowing of the valves due to that. That's less common, but we do still see that occasionally. And then, like the things people are born with, we talked about bicuspid valves, cleft valves, meaning, the scallops are not, appropriately coming together. This can cause, leaks and things, but these are usually identified earlier on in life.
Okay. Thank you for explaining that. Dr. Wong, Dr. Kaliyadan touched on this a little bit, but is there a relationship between heart valve disease and heart failure?
Yeah, so heart failure, it can go both ways. Okay. So if you have heart valve disease, and again, the valves can either be stenotic, which means if they normally open and close like this every time the heart beats, if a valve is stenotic and it opens like this, like a pinhole opening, that puts a lot of stress on the heart. Okay. And over time, that heart muscle tries to compensate by getting thicker and trying to really overcome this stenotic valve. But eventually, the valve will get so tight, the heart can't compensate anymore, and then it starts to fail and dilate, and you can have heart failure. On the flip side, you also have regurgitant lesions. So we talked about valves being tight and not opening. The other problem is when they close, they're supposed to close like this, so blood doesn't flow through. But you can have it where the valve doesn't close properly and blood leaks back into the heart. And so what happens is this is a different problem. The heart is trying to compensate for half of the blood sometimes that gets ejected out of this one-way valve that's supposed to allow blood to keep moving forward. It can actually um, uh, cause backflow into the ventricle, and the heart tries to compensate. And the way it does that is by dilating. So every time it ejects blood, it ejects more blood because it knows half of it's going to come back. But again, with all of these compensations the heart tries to do, there comes to a point where it can't do it anymore, and patients can present with heart failure symptoms. Now, I said it goes both ways because what I've described are primary heart valve problems causing the heart muscle not to work well, either getting too thick or dilating. But you can also have it the other way. So you can actually have heart attacks, for example, and you can develop cardiomyopathy, which is just a fancy way of saying that the heart doesn't squeeze well. And when the heart doesn't squeeze well and it dilates, the leaflets that are supposed to coapt and come together can't do so. So actually, by having a cardiomyopathy, again, a heart that doesn't squeeze well and starts to dilate, that can in turn cause or worsen heart valve disease. So really, the two are completely related. But for the most part, it's really heart valve disease can actually lead to heart failure.
Interesting. Okay. Thank you for explaining that. This was another one that was kind of touched on earlier, but I think it's important to reiterate. Who is most at risk for heart valve disease, and what are some of the risk factors that they might experience?
Is a really good question. And, looking at the epidemiology, and Dr. Kaliyadan touched on this, if you look historically, it used to be that rheumatic heart disease, having a streptococcal infection, and especially in developing countries where there was limited access to antibiotics, people develop rheumatic fever. And then the body has an autoimmune reaction to try and contain this infection and ultimately damages the heart valves, mainly the mitral, but also the aortic. And the damage doesn't present for years, decades. Okay. So people in young adulthood in their 40s and 50s, and sometimes 60s will develop problems with their mitral and occasionally aortic valve. As countries are developing better access to healthcare, antibiotics, we see less of this. Certainly in the United States, this is not a major cause of heart disease. When we do see rheumatic heart disease, it's usually from people who've emigrated from other countries. So worldwide, what we're seeing is a shift from rheumatic heart disease to really degenerate heart valve disease. And really what this means is that as we get older, the wear and tear on these valves are causing patients to develop this disease. Dr. Kaliyan touched on congenital. There are people that are born with abnormal heart valves, and they present usually earlier in life. But most of the heart valve disease is in the elderly now. And the risk factors to developing this are very much the same risk factors to developing coronary artery disease. So high blood pressure, high cholesterol, diabetes, cigarette smoking, because all of these things cause hardening of the arteries or coronary artery disease can predispose patients to have heart attacks. And like I mentioned earlier, this dynamic between the heart muscle not contracting well and heart disease is a very strong association. And so it's the usual risk factors of coronary artery disease are the same ones for valve disease. One other important point is that one of the main types of heart valve disease we haven't really touched on is infection of the heart valves. And that's called endocarditis when that occurs. And usually in healthy patients, even if you are transiently have some bacteria in the bloodstream, if your heart valve is normal, the bacteria doesn't like to seat on the heart valve. But if you have an abnormal heart valve that's due to the aging process or a congenital problem or rheumatic heart disease, if you go and even get your teeth cleaned and you are transiently bacteremic, in other words, have bacteria in the bloodstream, it can actually seat onto your heart valve and actually develop a collection of bacteria, what we call a vegetation on the valve, and it can eat away or destroy the valve. We see this also in patients that are unfortunately drug users, and they inject medications or drugs into their bloodstream, and it's not clean, obviously, and that bacteria that gets introduced can cause endocarditis. But for the general population to try and prevent that, one thing that's really important is good oral hygiene. So seeing the dentist regularly and making sure you have good teeth cleaning and good oral hygiene is really important for your heart health as well, something patients don't necessarily think about.
Yeah, I would have never made that connection until you just explained it. And once again, you kind of touched on this a little bit. Are there risk factors specific by gender or ethnicity? And taking that a step further, does heart valve disease affect men and women differently?
So I'm going to give the summary statement, which is that if you're a patient watching this and you're a man or a woman, or if you're of any gender or any ethnicity, you are at risk for heart valve disease. Okay. And I'll give you the more detailed explanation, which is if you look at the clinical trials and a lot of the epidemiology trials, a lot of our trials in the field of medicine historically have been done in men. And so we have very challenging epidemiologic data to go back and try and extrapolate and say, what is the real incidence in women? We know that it affects both men and women. There are certain valves that are associated to occur that type of disease more in women. For example, the mitral valve, like mitral valve prolapse. And aortic stenosis is thought to happen more in men. However, I will tell you that in a clinical practice of taking care of all of these different heart valves, we see equal distribution in men and women. Okay, we see as many men and women, and it's not like this is something that's only happening in men or only happening in women. And so, if you're watching this, you whether you're a man or a woman, you're at risk for heart valve disease. In terms of the ethnicity, this is a more nuanced question. There are some epidemiologic studies that show that in certain subgroups, they're less affected by heart valve disease, but by no means by being a particular ethnicity are you protected, okay?
Right.
So there are some epidemiologic studies that show, for example, the African-American population may have less aortic stenosis. Again, there could be problems in the representation of African Americans in our clinical trials. So this is a much more difficult question to answer, but I think, again, for the viewers of this, it's important to note that regardless of your gender, regardless of your ethnicity, you're at risk for heart valve disease.
Right. Thank you for explaining that. Shifting to diagnosis, Dr. Cohen, how is heart valve disease diagnosed and what tests are used to do so?
Yeah, so there's a variety of ways it can be diagnosed, but far and away the most common is an echocardiogram or an ultrasound of the heart. And it's important to know it's a painless procedure. There's no radiation involved or anything like that. And it's actually very effective in assessing both the heart function itself as well as each of the valves of the heart.
Okay. And how important is early detection in managing heart valve disease?
It's very important, and I can tell you from the surgical perspective, when things are done in a planned, coordinated fashion, as opposed to doing things urgently or emergently, the outcomes are dramatically different. And I think all of our colleagues on the call would agree with that. As an example, for aortic valve surgery and also really mitral valve surgery, particularly mitral regurgitation, if it's identified early and you're a fairly healthy person otherwise and have this kind of taken control of the outcomes, there's about a 99% chance of a good outcome, at least with surgical intervention. There's always going to be risk to what we do. We're always going to be upfront about that. But the important thing to remember is everything is a risk-benefit decision when it comes to these types of scenarios. And with outcomes that good, when it is a 99% likelihood of a good outcome, that's why some of these therapies are so effective.
Okay. And now, once again, we've talked about this a little bit earlier, but to go over again, does heart disease affect those of a more advanced age, or can it happen at any age?
Yeah. So like you said, we've touched on it already a bit. Without, saying too much, I literally just got out of the operating room operating on a 30-year-old, for aortic valve disease. So this can affect anyone. Yeah, obviously the older you get, the more likely things are to occur. But it really does affect everyone.
And then this is a question that I'm sure everybody wants to know the answer to. Can heart valve disease be prevented?
So in part, yes, but it's sort of that's a very challenging question. It's not really a binary or yes or no answer. So there are things that we can do in terms of our lifestyle that will lower the risk. But you could do everything perfectly, eat the perfect diet, be a marathon runner. And I'm sure, again, everyone on this call has taken care of folks that have done literally everything right. And there's just some things there's a very strong genetic component to heart disease, or that's coronary disease, valve disease, and so forth. So you want to live a healthy lifestyle, lower your risk, but it doesn't mean that you're free from this kind of stuff.
Yeah. And what are some of those things that we can do to lower our risk? You mentioned, I'm sure, exercise, healthy diet. Is there any specifics to those or any other tips you have to lower the risk?
The perfect diet, I probably, I don't think anyone actually knows the answer to that. The other big thing, and it goes without saying, is not smoking. It is a huge component. Not even simply to valve disease. What you have to remember is when it comes time to potentially have to intervene on these things, whether it's in the cath lab or in the operating room, it's those comorbid, I hate to use that word, but those other conditions or challenges that you might have that can be very much tied to smoking. In particular, peripheral vascular disease, is a big problem. It increases your risk for having any type of procedure that we can do, and not lower your risk.
And then
Sarah, just to add to that, just to add on to that, I think, we had touched on this, but I think controlling the risk factors, so diet and exercise, controlling your weight, right? But we talked about going to the dentist. That's great. And then high blood pressure, making sure you take high blood pressure seriously, control your blood pressure, because a lot of patients don't feel bad when they have high blood pressure and they don't take their medicines. But over time, that kind of stress can lead to heart valve disease. High cholesterol. Making sure your cholesterol is under control. Diabetes. If you have diabetes, you have to make sure your sugars are in control, and your A1C is, which is a measure of the long-term exposure of how high your blood sugar is. Make sure that's under control. So there are a lot of risk factors most people think of as coronary disease, but they also affect your heart valve as well.
So the one other interesting thing patients ask a lot, because we talked about calcium building up on the valves, and they ask all the time, well, should I eat less calcium in my diet? And the answer is no, keep taking your calcium supplements and dietary calcium. That has never been shown to build up calcium on the valves. So that's a frequent question we get from our patients. So I just want to make sure we say that for all our viewers out there.
And one other point is that we haven't really touched about this because we don't have representation from our EP colleagues or electrophysiology colleagues, which are the heart electricians. But atrial fibrillation is the most common arrhythmia in America as we get older. and really making sure that you seek out your cardiologist and have that well managed. Because over time, if you have arrhythmias that are not well managed, that can lead to heart disease, heart valve disease, muscle contractile problems. So really, in addition to looking at all of your cardiac risk factors that you can control, what we call the modifiable ones, obviously you can't pick your parents, right? You can't alter your genetics, but the ones we can do, like Dr. Cohen said, not smoking, living a healthy lifestyle, getting routine healthcare maintenance, making sure you take all these risk factors seriously. Those are the best things we can do to try and prevent heart disease. And with that said, people are still going to develop it.
Right. Thank you all for your input on that question. That's all some very good points that you made. And once again, this is my next question. Talked about it before. I think it's important to go over again. What are the symptoms of heart valve disease? And then I'll also add on, at what point maybe should someone see a doctor if they're experiencing these symptoms?
Yeah, the symptoms are widely varied. And again, this isn't to scare anyone or be dramatic, but one of the most common things that I see, and again, I'm sure that everyone here sees, is valve disease. It progresses for the most part slowly over time. So you kind of get used to it as a human being. And you chalk up your symptoms to just getting a little bit older. Oh, I can't quite do as much. I'm a little bit more tired. I get a little short of breath when I exert myself. I'm just an old person now, that's normal. And that's not always the case. These types of, whether it's aortic stenosis, much regurgitation, they can give you these types of symptoms. Now, as they advance, you can get more short of breath, chest pain, lightheadedness, passing out even, and the worst scenarios being having MIs and so forth. But again, it all leads back to the same thing as seeing your primary care doctor, your cardiologist, to keep an eye on these types of things. And these types of valvular problems can be identified as early as, simply listening to one's chest. The stethoscope is an old, device, but it works, especially as a screening tool for identifying some of these problems.
Yeah.
And I think in addition to that, Sarah, I think patients, if they notice swelling in their legs, that's a very common symptom, what we call lower extremity edema or swelling in their legs. Sometimes they can just feel bloated, like they're carrying a lot of weight, extra weight on board, and being short of breath, being tired, just having no energy. It can be really subtle things. It doesn't have to be dramatic, like you just can't catch your breath. And like Dr. Cohen said, this is really insidious. It happens slowly over time, and people don't like to feel symptoms, so they ratchet down what they do so they don't feel bad. But if you start asking their spouse or sometimes the other family members, they'll notice that the patient has had a precipitous decline. But the other things that we talked about, really shortness of breath, swelling in the legs, lack of energy, not able to do the things you're able to do before. These are some of the most common symptoms patients face.
Yeah, I think the exercise tolerance is a really important one because people do like less and don't realize they're doing less. So it's sometimes helpful to ask the spouse or someone else who's kind of more objective, chest pain, unexplained fainting episodes, these are all things that you have to like seek medical advice, and don't ignore these symptoms. Talk to your primary care physician or your cardiologist, if you start experiencing any of those symptoms, to make sure this is not due to a valve. And these symptoms are general, right? So they could be related to a whole lot of other things. But if you have chest pain, if you have shortness of breath, if you have swelling, that seek out medical attention for those issues, because it could be a serious problem.
Yeah. Yeah, I think that's important. I know I sometimes have a little bit of a fear of going to the doctor, so I'll put off, I'm just, out of breath because I'm out of shape or something like that. And so it's important to bring these things up with your doctor and, get down to the core issue of what's going on. So I'm going to pause for a second and thank our viewers. If you're just now tuning in, thank you for joining us. Today, we're discussing heart valve disease, what it is, the risk factors and symptoms, and the latest treatment options. Fortunately, valve disease can often be successfully treated in patients of all ages. Although heart valve disease risk increases with age, it is not a normal part of aging. And we have a lot more to discuss, so stick around, give us a like to let us know you're watching. And if you have any questions for our experts, please leave them in the comments below. And we actually do have a couple of questions from our viewers, so I'm going to get into those really quick. We have a question from Janice. What is the best treatment for mild mitral and tricuspid regurgitation?
Well, if you have mild mitral and mild tricuspid regurgitation, there's a very good chance that you just have to be followed carefully with your doctor and be placed on medications. And the importance of establishing care and having a regular follow-ups is to make sure that they can monitor this, that the medications are working and the heart valve disease is not progressing. Trace, what we call trivial or mild leakiness of heart valves is very common as long as we get older, and many people live with this. So if it's in the mild range, most of those patients can be treated successfully with medications and just followed carefully over time by their doctors, physical exam, as well as having ultrasounds of their heart on a somewhat regular basis.
Okay. And then we have another question from Laura. Does rheumatic heart disease have anything to do with rheumatoid arthritis?
Yeah, that's a good question. I can take that one. So the rheumatic when we're talking about rheumatic mitral or rheumatic aortic disease, we're talking about what Dr. Wang had touched on earlier, patients who have rheumatic fever. So this is why, when our kids get strep or have different illnesses, we take them and put them on antibiotics so these bacteria don't seed the valves and cause inflammation of the valves over time. Rheumatoid arthritis is more of an autoimmune issue, which that is not directly affecting the heart valves. So that's more of the causing all the arthritis issues and the joints and hands but these do not typically cause, valvular abnormalities. So, so it's a kind of a little different thing, even though both have rheumatic in it. We're talking more of the kind of illness from childhood, viral seeding versus the autoimmune process of rheumatic arthritis.
Okay. And then one from Alicia. Can you speak about arrhythmic mitral valve prolapse?
Rhythmic mitral valve prolapse?
Mm-hmm.
Well, so mitral valve prolapse in general is basically when the leaflets, or it's usually one leaflet of the mitral valve. The mitral valve has two leaflets or two components that make it up. And if one of the leaflets is prolapsing, it doesn't allow the valve to close properly. Okay, so then every time the heart squeezes, or the left ventricle of the heart squeezes, when that valve should normally shut nice and tight so blood doesn't rush backwards towards the lungs, it rushes backwards, and that's what mitral regurgitation is, and prolapse causes regurgitation. Now, sometimes when that blood rushes backwards, it affects the left atrium of the heart, and that can lead to arrhythmias as well. So that might be what we're referring to here. Now,
Okay.
the regurgitation affects what our treatment options will be, or what the plan will be going forward. And we do have a lot of treatment options for mitral regurgitation.
Okay. Thank you. We have another one from Elena. Is sleep apnea related to heart valve disease?
Well, sleep apnea can cause a whole host of problems, including elevations in your pulmonary pressures, and puts a lot of stress on your heart. So in general, it is one of these risk factors to your overall health. And so indirectly, yes. And certainly patients that have pre-existing heart disease are not going to do well if they have obstructive sleep apnea that's not treated.
Mhm.
So it is important to make sure that's taken care of as well.
Yeah.
And I think it can lead to a lot of other risk factors we talked about, uncontrolled hypertension. It can lead to weakening of the right heart, high lung pressures, and all of these can functionally cause leaking of the valves and contribute to valvular heart disease. So in general, that's one of the big things, not just for valvular heart disease, for overall health. Treating sleep apnea is a really important thing to do.
Great, thank you. And last one from Jeanette. After heart valve replacement, and if you're pretty healthy, how long does the heart valve last before replacing? Or how long does it last?
Yeah, so that's a really good question. And the short answer is it depends. It depends on the person, depends on the valve, and so forth. Generally speaking, for our most common valve replacements, we're talking about the aortic valve. That's the most common valve that we're going to replace. And that's like I said, it's a loaded question. With regard to the prosthetic valves or the bioprosthetic valves, the likely lifespan of those valves or the generation that we're using now is likely in the neighborhood of 10 to 15 years, most likely. Those are the valves that don't require a high level of anticoagulation or blood thinners, anything like that. We typically just have folks on a baby aspirin with these types of valves. With regard to TAVR valves, I don't know how deeply we want to dive into this. It's a little bit less clear to know for sure how long the valves will last. And like I said, the important thing to remember is that there is a degree of variability. All of this is based on large statistical pools, and it can vary from person to person. But generally speaking, we quote folks, between 10 and 15 years for surgical aortic valves that are replaced. And the tissue valves, mechanical valves, and those are the valves that you will be on blood thinners with or warfarin. They can last much longer, 20, 30 years and so forth, potentially.
Okay.
Think that,
Oh, go ahead. Sorry.
Bursting at the seams there.
I think the other generality to add on to what Dr. Cohen said is that the older you are, typically patients are less active, and the valves seem to last longer in that population. And when you treat heart valve disease in people that are in their 30s, 40s, 50s, and 60s that are much more active, the heart valves don't last as long. So it really depends on the aortic position, the mitral position. These are very different locations of heart valves that see very different pressures and have to deal with very different pressures. And the durability of these valves depend on a lot of factors. And that's definitely something that you would want to discuss with your doctor. The other thing that's patients may have heard this term, it's called lifetime management of their heart valve disease, because heart valves, we know there's a lifespan, right? No matter what kind of valve you put in, it's not going to last forever. It's remarkable that human heart valves last as long as they do, right? I mean, think about it. These are 2 or 3 pieces of tissue. And if you have a patient that's 80 or 90 years old, they're still working. They're 80 or 90 years old. I mean, there's no mechanical engine I know of that is working at 80 and 90 years old, like the heart, when you think about it that way. What car engine do you know runs that's 90 years old, right? But we see 90-year-old patients and their heart valves are doing okay. So it's remarkable they last as long as they do. But when we replace it either with something through a catheter or surgically like Dr. Cohen, it's something that's manufactured with tissue and sewn onto either a sewing ring or a stent. And despite all the efforts to make sure that we treat these leaflets to make sure they don't calcify, they're all eventually going to fail. So when we have discussions with patients, we do keep in mind, and we're realistic with them, that this may be your first valve, and you may very well outlive this one and need a second valve, and that can determine the strategy or approach. So when we're dealing with very young patients, even though they may be candidates for a catheter-based procedure or open heart surgery, we may very well say to them, you should go get open heart surgery for this valve the first time. And if and when 10, 15 years it fails, then we can do a catheter-based option. And we've done it the other way around as well. We've done catheter-based options first, and we've said to patients, listen, in the future, I think the only way to fix this, if you're not a candidate for another catheter-based replacement of it, is to have open heart surgery. So very nuanced discussions. That's why it's important to follow up with your cardiologist. And when you do consult with your surgeon or interventional cardiologist or the heart team, they do take into account your age, how long these valves last, and how many more procedures you may need in the future.
Yeah. Thank you all for explaining that. Yeah, that will go into a question I have later on about determining best treatment approach for each patient. But before we get into that, thank you to our viewers for your questions. And my next one is talking about quality of life. How does heart valve disease affect a person's quality of life and their daily activities? And then are there any emotional or mental challenges they may face after being diagnosed?
Yeah, I think so typically when you get into the more advanced sort of phases of valvular disease, we touched on the early phases when you have mild or mild to moderate either stenosis or regurgitation. But once you get into the moderate to severe range, that's when the body starts feeling symptoms, and that's when you started really exhibiting symptoms. So in terms of we talked a little bit about not being able to get around as well as we used to. We're not able to do all the activities and the things we used to do that we like to do, whether it's going grocery shopping, doing stuff around the house. Like I'm really winded. I can't do anything. And even some people, even just sitting there, look out of breath. And these are all things, that people experience with severe valvular abnormalities and valvular heart disease. And emotionally, yeah, that does take a toll on people because you've lived with this heart all your life, and then now all of a sudden, like my heart's not working or it's broken, because I have this valve issue. And I think that's really for patients, I know we see this as physicians, we see this every day, but it's very personal to each of our patients, when they have this problem. And I can tell you how grateful patients are after the valve problem is fixed. And they say, Doc, I didn't realize how bad things were until my valve got replaced or fixed. And they're like a brand new person, and they're able to do all those things. And they never realized, how bad things got, because it truly is insidious. It's over many, many years. Dr. Cohen touched on this. And then you fix the problem, and then they're like, back to, and we have as physicians, we've experienced this story from a lot of our patients who are now able to do things, travel the world, to do all sorts of things that they were not able to do because of their valvular issues. It is we're very privileged to be taking care of these patients and helping them with these problems. And I know, like, after their valve issue is fixed, I know patients feel like a big weight's lifted off their shoulders.
Oh, I love that. That's great to hear. And kind of in that same, talking about how it can be a emotional, mental stress going through diagnosis, how can family and friends support a loved one living with heart valve disease?
I think the listening to them and maybe understanding that if, for example, they may not have the energy to participate in certain things, it may not be because they don't want to, but because they actually don't feel well, and being sympathetic to the fact that they have a medical condition that may be affecting their daily lives without them even knowing it. And so I think listening and being supportive, and I think those are just really understanding that that particular person is going through a lot other than, perhaps just what on the surface it may appear.
Yeah,
And not to confuse it with lack of interest or wanting to participate in activities or friendships, etc.
right. Yeah, I think that's important to remember. And I'll ask this to you, Dr. Wang, because you touched on this a little bit earlier. How do physicians determine the best treatment approach for each patient and, decide whether to recommend surgery for heart valve disease?
Yeah, it's a great question. So, the first thing when you have a patient that has heart valve disease that may be identified by a doctor listening with their stethoscope, right, or with an ultrasound of the heart that shows there's heart valve disease, is they usually get managed medically with medications by their general cardiologist. When the disease gets moderately severe or frankly severe, then they usually get referred for further testing. And this testing usually starts with a heart catheterization by an interventional cardiologist to see if patients have blockages in their blood vessels contributing to the heart valve disease, and also to measure the pressures in the heart to see what kind of damage has been done in terms of their lung pressures and are they carrying extra fluid on board. And sometimes when we get to that point, if we just fix the blockages in their blood vessels or get them euvolemic, which means get the extra fluid on board, we can continue to treat them successfully with medications, often in conjunction with a heart failure specialist. But then when it comes time to actually having a procedure done, this is when we really employ a heart team approach. And for any particular valve that we're thinking about intervening, we always have our cardiac surgery consultants and our general cardiologists and the interventional cardiologists discuss these patients as a group because the right therapy is not going to be the same for every single patient. And every patient has to be approached individually, and the right decision has to be made for them with this heart team. And so usually when it comes time to actually having the some sort of a procedure done, that's when the heart team will meet and review the patient's all the data that's been collected up to that point.
Interesting. I love the team approach. I love that. And so getting more specific about treatment options, Dr. Kaliyadan, what are the medical treatment options for valve disease?
Yeah, so medically, you can optimize patients in terms of if they have a weak heart muscle because of the leaking of the valve. We use medications like diuretics. We use medications to treat weak heart muscles. Medications like beta blockers, ACE inhibitors. Different medications. These are what we call guideline-directed medical treatment. For heart failure. So a lot of it is aimed at treating symptoms, optimizing patients in terms of their fluid status, their volume status, and then also to optimize the function of the heart as well. But it's what I always say, valve problems they're most often are mechanical issues. And we don't really have a medicine to make the calcium go away, for instance, on the valve. So because it is a mechanical problem, it does need a mechanical solution, whether that is a surgical valve replacement, a transcatheter mitral or aortic valve replacement, whether it's a clipping of the valve to bring the leaflets together so it closes more appropriately. The medical side is sort of to make people feel better, but it doesn't necessarily do anything to treat the underlying issue. Now, sometimes the medical therapy does help reduce the amount of leak, for instance, in a valve, and patients can be managed medically for a point. But if there are significant things, and that's why every patient, this is very general because it's different for every patient, but there are some problems you can treat with medicines, and then ultimately you do need some more intervention on the valve. And that's why it's important to consult with your physician on your specific valvular issue.
Right. And then, Dr. Cohen, on the other hand, what are some of the surgical treatment options?
So there's a broad-based approach to surgical treatments for valve disease. We have lots of options, things ranging from, the traditional open heart approach to more minimally invasive options where we sometimes can go between the ribs to avoid having to go through the sternum, or even using the Da Vinci system, the robot, which isn't really a robot. It's still controlled by a surgeon. I think that's important to clarify. And that's particularly useful for the mitral valve, and in particular, really mitral regurgitation. Robotic mitral surgery is very, very good and very effective, and the outcomes of or good outcomes have really been demonstrated. Again, I know we touched on this earlier, but again, this is the kind of thing we can also tailor to the individual. There's a lot of subtleties to this in terms of what is the best approach to take when it comes to surgical options for heart disease or valve disease. And the other component to it is, again, when it's done in a planned, coordinated fashion, not urgently or emergently, folks do really, really well overall. They really do. And that just speaks to, seeing your doctor, seeing your cardiologist, and getting these things treated if they have to be. And I know it's scary. Listen, I just turned 41. I finally started going to the doctor again. I did it. Yeah. It's not always the easiest thing to do, but at the end of the day, it's going to help you in the long term.
Right. Yeah, exactly. And Dr. Wang, I know you have to hop off soon. So real quick, talking about TAVR. Oh, I'm sorry. Did I cut you off?
I am sorry. I got to get to the airport.
Oh, okay. Well, thank you for joining us, Dr. Cohen.
See you guys.
Take care.
And then Dr. Wang, I know you have to hop off soon too. So if you have a second to talk about TAVR procedure.
Sure. TAVR, TAVR, transcatheter aortic valve replacement. This is something that was FDA approved in 2011 in the United States. It's remarkable because prior to this, if you needed a new aortic valve because your aortic valve became stenotic, full of calcium, and doesn't open well, you had to have open heart surgery. And many patients were not candidates for open heart surgery because they're too high risk. So this procedure, when it was approved, was initially approved only for those patients that were not candidates for open heart. So high risk, no one would operate on them. And it was remarkable, even that first generation device, which was much bulkier, much harder to deploy the valve, patients did better. Then it was actually studied in patients that are high risk for open heart surgery. And TAVR showed that it was superior in those patients, less invasive, faster recovery, as durable. Then it was studied in moderate risk or intermediate risk for open heart surgery patients. And again, it was positive results. And most recently, in the last few years, it was studied in standard risk patients, and again, shows comparable results. So what this procedure is now evolved over the last decade, just over a decade, to placing a catheter into the femoral artery in the groin that's about the size of a pencil. And it's actually done, believe it or not, with patients awake under light sedation, and they're able to talk to us. They're numbed up. It's not uncomfortable. We then pass up a small wire and catheter, and we first use a balloon to open that calcified valve, okay, what we call predilate, to make way for the new valve. The new valve is either mounted on a balloon that we expand, or it's a self-expanding valve that we turn some dials and the valve expands to the size that we want in its proper location. And for the balloon expandable type, when we expand the balloon, deflate the balloon, the new valve starts working immediately. It gets locked into the old valve. We don't take the old valve out, and the new valve starts working immediately. For the self-expanding type, we turn some dials and this new valve expands. And once we assess that we're perfectly happy with its location, then we release the valve. So with either of these two types of replacements, the procedure lasts about half an hour. And when we're done, we take everything out and patients go to the recovery room. I would say 85% to 90% of the patients go home the next day.
Wow.
And patients feel that this procedure is much more similar to a heart catheterization than anything remotely like traditional open heart surgery. That's in brief what transcatheter aortic valve replacement is, or TAVR.
Wow, that sounds incredible. Thank you for explaining that. And if you need to jump off, you can. Otherwise, I'm gonna ask Dr. Kaliyadan if you can talk about some recent advancements in treatment for patients.
Yeah, so one of the we started this journey into transcatheter valve replacement with the aortic valve. So this was like when I was in training, like this was the latest and greatest. And I never imagined that now we can essentially replace or repair every single valve inside the body through catheters, okay? And the latest one that we are able to repair and or replace is the tricuspid valve. And there's been a lot of attention to this valve. When I was in training, we called this the forgotten valve because, it was one that was not easy to treat through even surgical means, as an isolated problem. But now we have a way where we can actually go in and treat leaking of the tricuspid valve, which can cause issues with the right heart and building up fluid in the legs, shortness of breath, by either clipping the valve together through a process called transcatheter edge-to-edge repair using a clip to bring those leaflets together. And now, most recently, we just recently did two of the first transcatheter tricuspid valve replacements using a new system, new valve that will completely replace the tricuspid valve and allow it to function in a more normal fashion. So we just did those two of those in January, and those patients have done quite well. And that's kind of the latest and greatest. But now we can do, it's remarkable how much advancement, and we as physicians, we can't take credit for all of this. This is the engineers who have come up with these delivery systems, the different industry folks who have helped to develop all of these valves. It truly is a team of physicians, our partners and who are in industry who are developing these great technologies and just making it better and better for us. That it's of course the trust that our patients have in us to take care of their valvular disease as well.
Yeah. Well, that's great to hear and very exciting stuff. That's all the time we have for questions today. Thank you to our experts for joining us, taking time out of your schedule to educate our patients. And thank you to our viewers for joining us and asking your questions. To learn more or to make an appointment, you can visit us on our website, medstarhealth.org. We'll be providing specific links in the comments. Thank you, and we will see you next time.
Thanks, everyone.
Thank you.